So welcome everybody to our Facebook Live with PATH. I'm Carmina Cerioli, the co-executive director for PATH. Morning. So welcome everybody. Tonight's topic is a live, which is all about newborn screening, and we'll be answering some really important questions that a lot of families, I'm sure, have been asking or would like to hear. So let me start by introducing two of our PATH staff. We have Marnie McNiff, who is our parent support advocate and our communications coordinator. There she is. She will be keeping an eye out to see if there's any questions, and she'll make sure that she asks our guests those questions as we go. So feel free to just type in your questions there and she'll be able to keep up on it. And then we have Joy Hunter, who is our genetic resource coordinator, and she will be helping me facilitate the discussion tonight. So tonight we are joined by two amazing women who we have gotten to know for the past about year and a half, 2 years now. They work at the Connecticut Newborn Screening Network at Connecticut Children's Medical Center. So we have Debbie Ellis. She is an RN with over 20 years of experience in the NICU and early childhood. In her current role as a program coordinator for the Connecticut Newborn Screening Network, she oversees referrals to the network for out-of-the-range newborn screens and helps to design and implement programs or projects to support providers and families. She is passionate about improving the experience for families as they navigate the newborn screen system. So welcome, Debbie. And we have Ginger. So some of you might remember Ginger joined us for a Facebook Live in January. She is a genetic counselor who has been working in the field of genetics for close to 23 years. She is currently working with the Connecticut Newborn Screening Network and is available to talk with all families who have a baby that was diagnosed with a medical condition following newborn screening, and for families who have a newborn going through follow-up testing because a newborn screen flagged for more testing. So welcome both of you guys. We're really excited because this really is a hot topic. And we really want to get the word out to families, what is newborn screening? Why is it so important? So we have some questions here that we're going to ask, and Joy, feel free to start.
So our first question is, what is newborn screening?
Well, thank you for letting us talk. I think it isn't, like you said, important to get word out about newborn screening, because even just this week, I heard some families asking questions about newborn screening. And it kind of surprised me that they didn't know some of the questions that they were answering, because since I'm in the field, I kind of feel like everyone knows it. But so newborn screening actually happens for all babies across the United States. And most states will do kind of 3 different parts of newborn screening. One is a hearing screen, and one is a screen to look for heart defects. That's with a little pulse ox, measures the blood flow in the blood. And then the part that Debbie and I are involved in is called the blood spot screening. So that looks for close to 70 different medical conditions that it's important to screen for, because babies who are born that have these conditions don't show symptoms or signs of it when they're born. And then symptoms can show up later in life. But if we catch it early and start treatment early, we can stop the symptoms and have good, healthy development going forward. So that's kind of a big general overview for newborn screening, but all babies do get it. So the questions that I heard this week that came up was, well, my baby didn't get it because they're in the NICU or they're in the foster care system, but actually they also will get it. So all babies get it, whether they're in a NICU, a regular nursery, whether they're in the foster care system or going through the adoption process, all babies are going to have it. And the newborn screen blood spot part comes, there's a little heel stick. They prick the baby's heel and put drops of blood into a piece of paper called a filter paper, and that goes to the lab. It's usually done in Connecticut around 30 hours after they're born. So when they're 30 hours old, just slightly over 1 day. But I'll let Debbie add any other info she wants to add.
That was great. I think that what it's important to know also that newborn screening is done on all babies, and it's to find conditions that could be hidden at birth. So a baby may look very healthy at birth. There might not be any family history of a condition, but we can determine with newborn screening if a baby is at risk for a condition and begin the workup and begin treatment and start treating that baby before any signs or symptoms, excuse this, even start to manifest themselves. And if we begin it early, then we can stop any medical issues from happening or any developmental delays. And we screen for conditions that have treatment available. I can't hear you, Carmina.
You're on mute.
Sorry. Yep, got it. So you had said that you scan for about 70 different conditions.
Yes.
Do all the states scan for the same, or some states not as much or more?
No, every state screens for a different number of conditions.
No.
There is a RUSP, which is the recommended uniform screening panel, which are the basic conditions that every state is supposed to screen for. So I think all states screen for 20 basic conditions, and some screen for 30, 40, 50, and in Connecticut, we're up to about 70. So we screen for one of the most amounts in the country.
Wow. And do more get added as years go on if something comes up?
Over the past couple of years, we've added several more conditions.
Just have a quick question, and I usually don't burst in. So bursting in, would you be able to, oh, and my dogs are bursting in. I was wondering if you could say what a few of those conditions are, just to give, obviously not all 70, but just to give people an idea of what types of things you're screening for.
Absolutely. Probably the one that you've heard of the most, or that most people have heard of, is PKU. And in fact, this is often a confusing term because a lot of people call it the PKU test instead of the newborn screening test. So PKU, or phenylketonuria, is a condition in which the body can't break down proteins very well. So as a baby eats proteins, they're not broken down, and it can cause damage to the body and some medical issues. And this was the first condition that we were ever able to screen for. And in the 1970s, we began screening for that. And over time, more and more conditions were added, but the healthcare system, pediatricians and healthcare workers continued to call it the PKU test. And to this day, many pediatricians and healthcare providers still call it the PKU test. And this can be very confusing to parents when they hear that their baby had an abnormality on the PKU screen. They will research PKU, they learn about PKU, and that was not the condition that their child is at risk for. So it can be very frustrating for them. Some of the other common conditions that are flagged are endocrine conditions like congenital hypothyroidism or galactosemia, where a baby has a difficult time breaking down galactose in breast milk or formula. There's a wide variety of genetic conditions like carnitine uptake deficiency.
And that also screens for the hemoglobin disorders like sickle cell or hemoglobin C disease or beta thalassemia, alpha thalassemia. But there are a lot of metabolic conditions in that group. So like she said, the PKU, carnitine uptake, galactosemia, medium chain acyl-CoA dehydrogenase deficiency. There's so many, there are these long names, and they're rare. And like Debbie said, people often are surprised when their baby flags for it because they'll say there's no family history, but the way most of these disorders are inherited is through a recessive pattern, which means a person needs to have 2 copies of the gene that causes the disorder. They get one from mom. We get 1 gene from mom and 1 gene from dad. And so everyone's walking around usually with 1 gene that has a change on it. We call it carriers. We all are carriers of something. We just don't usually know what it is. And so it's not uncommon. It's very unlikely actually to have a family history if there's a recessive disorder running through the family.
That's interesting. But yeah, we were one when my son was born like 26 years ago. I always throw that in there, but it was the PKU test. Yeah. So, and I thought, and it was never addressed after that. You know, I don't even know what his results were. I mean, I don't know anything. All I know is he had a PKU test, and that was the end of it. And again, being new, I never even questioned it. I'm like, oh, all right. I'm guessing there's nothing wrong because they didn't come back to me. You know, that's the way my mentality was at that point, you know, which is kind of crazy. But so why, and can you explain to us why is newborn screening so important? I think you kind of touched upon it a little bit before, but we know it's extremely important. And yeah, I would like to get a little bit more in depth in that.
I think it's important because it can save babies' lives. Before newborn screening, you wouldn't know that the child had a condition. You would continue to feed that baby as normal. And meanwhile, toxins could be building up in the baby system, and you could have a medical crisis. If we can identify that a baby has a condition and begin treatment before symptoms even begin, we can avoid medical issues, hospitalizations, long-term developmental delays, and even death.
Wow. Okay. So it is very important. Yeah, definitely. And I know we'll talk about follow-up also, because that's extremely important. You know, you may get, you know, tagged or flagged, but it's that follow-up that you want to address.
I think I just, just for 1 second, we have someone concerned they were questioning why we don't have a doctor on the panel. So if you could maybe tell your qualifications so they understand, you know, who you are. And I know Carmina said some of that in the beginning, but perhaps it was missed. I think that would help clarify for the person asking. I would thank you.
Absolutely. So Ginger and I work for the Connecticut Newborn Screening Network. And in Connecticut, there's 2 parts to the newborn screening system. The Connecticut Department of Public Health does all newborn screening blood spot cards go back to the Connecticut Department of Public Health lab in Rocky Hill to be tested and screened. If those screening cards flag is out of range, the results come to us at the Connecticut Newborn Screening Network. And that's Ginger and I and our team of nurses and doctors. And we evaluate the newborn screen. So depending on the results of that screen, we will review it with a physician. So it may be a geneticist, it could be an endocrinologist, an immunologist, a hematologist, depending on what the condition is that the baby flags for. So not all newborn screens need to be reviewed by a geneticist. We'll direct it to the doctor that it is specifically for. And for some of the more common conditions, we have algorithms where our nurses can review them, and we know that if the labs fall within a certain range, we know the proper steps to take to order the correct labs or guide parents to the next step. Once those labs are done, we'll present the whole case back to the doctor, and they'll review the case and determine what the next steps are from there. Sometimes when we have a newborn screening result, the initial result is still out of range or very concerning, and we'll bring that baby in right away to meet with the doctor same day or next day, depending on the results. But almost all of our screens are seen by a doctor and evaluated by a doctor at least once, if not 2 or 3 times during that process.
Thank you. And Ginger, do you want to just, because somebody, they might have not been on the beginning part when I introduced you both. Do you want to just introduce yourself real quick?
Yeah, so I'm a genetic counselor. So you're right, I'm not a doctor, but so my background is in medical genetics. I've been doing genetic counseling for close to 22 years. But I did want to step back to something that you said, Carmina, that when you said you didn't even know about the results, it was very common for the results, if they were within normal limits, to not really be like given to families. Just recently, the state lab is now giving all results, whether they were flagged for more testing or reported as within normal limits, back to the pediatrician. So you can ask your pediatrician for the results for the newborn screen for your baby. And if they don't have it, they can reach out to the newborn screen program to get the records. I don't know how far back they go, but they go back pretty far with their records if you need to get someone's newborn screen.
Really?
And also, I want to just clarify, our role tonight is not to give specific medical advice about newborn screening conditions, but more just to educate about the newborn screening process and system in Connecticut, because I think there's a lot of misinformation or lack of information out there.
No, you're absolutely right. Because there's a lot of like we were saying, lack of follow-up, because they don't understand really what that means. Why, why are we having our babies tested? Why is it so important? So yes, this is really just trying to get the word out, like you said. So Joy, you're up.
Is newborn screening different from newborn blood spot screening?
So there are 3 parts to newborn screening, and the newborn blood spot screening is the part where they do the heel stick and on the filter paper. That in Connecticut, we screen for about 70 disorders. So the other 2 pieces are, while they're still in the hospital, they'll have a hearing test and a screen for serious heart defects. And so that information, I think they go over those results while you're still in the hospital. And then it can take a few days for the blood spot screen results to come back. So sometimes families are at home before they get those results.
And how long did you say it would take from the time that they get the blood spot and bring it, send it to the lab? And is it like 2 days, you said, for the parents to get a call? Or
it might be a little bit more than that. Some of the results are back within a couple of days. Mm-hmm. Some of them can take up to 5 days. So usually it's a couple days after you're home from the hospital that you would get it. But we are encouraging all pediatricians to let parents know the result at the 2-week visit. It used to be that if everything was within normal limits, nothing was really said. And we think it's important to communicate those results, even if they are within normal limits, so that everybody's aware that it is happening and that the result was within normal limits. And if you don't hear about the results at your visit, then definitely ask your doctor.
Normally, I think the baby goes back to the doctor after 2 weeks. Is that correct? Yeah. Okay, good. And I think you answered this one, Ginger. Is the newborn screening necessary if a family has no history?
Yeah, sorry, I just start to ramble. Yeah, so it's often there isn't a family history. We do have some families, if they've had one child born and diagnosed with a condition, they go on to have other children. Sometimes they'll have, their second or third child might also end up having the same disorder, but it's rare that there is a family history, and like aunts, uncles, grandparents, we don't usually see that.
How do parents find out their baby's results? I think you answered that.
So that's where you should definitely ask your healthcare provider at the 2-week visit if they don't bring it up and volunteer that information.
Yeah, and that's the thing too. So I think at that 2-week mark, you should at least have something back.
Yeah, the DPH is trying to send a fax to all the pediatricians at around the 2-week mark to let them know the results. And if the doctor doesn't have that yet, they should reach out and get it and just record it in the baby's record.
So who would, I'm sorry, go ahead.
Yeah, because I don't remember ever getting results when I had my children. So that, it was always the theory, no news is good news. But like you said, it'd be really good if they just gave them something, whether it's good news or bad news, let them know something either way. So that is important.
Right. Because you're left. Yeah, and you're right. You do feel like, okay, I didn't hear anything. Everything's good. But you wonder how many have either, didn't get that call, missed, and then, but another thing. But so who would actually make that phone call? So if the results came back and it was flagged, would it be DPH? Would it be your doctor?
So if the newborn screen is flagged, we would reach out to the pediatrician and let them know. We would call and say, are you taking care of this child? Have you seen the baby yet? How is the baby doing? Is the baby gaining weight? Do you have any concerns? The newborn screen was out of range for this condition. And this is what we would recommend as follow-up steps. And we would then ask the pediatrician to call the family and explain to them that the newborn screen was out of range and that these are the next steps, whether that be an appointment with a specialist or blood work or a phone conversation with Ginger or I.
What does it mean if the results are out of range?
So that's good. When it's flagged out of range, so it's important, I guess that this is a good step to say, newborn screening, if it's flagged for more testing, newborn screening is not a diagnostic test. It was actually designed to see which babies would benefit from more testing. So because more testing often involves a blood draw or a urine test, that's not something they want to just do on every baby that's born, the more diagnostic testing. So if it's flagged, it just means the baby needs to have some more testing. Doesn't mean they've diagnosed anything. The newborn screen, some of them, it is a little bit better at screening for some conditions versus others. So some we might be a little bit more suspicious that this baby, yes, this baby probably does have it because newborn screening is better for that disorder. And then there's some disorders where we say, wow, we're used to seeing a lot of what we would call false positives with a newborn screen. And when the baby goes on to be tested, we're able to say, no, the baby doesn't have the condition. But I'll let Debbie add because she was going to say something too.
No, that was great. I just wanted to add that most babies that do need follow-up testing are healthy and do not go on to have a diagnosis. There are a lot of false positives. And this could be because the sample was too small. Maybe it was collected too early or too close to a feeding. If the baby was in the NICU and was low birth weight or was receiving special formula or a medication, there's a wide variety of reasons why you may have gotten a result that was not typical. So it's important to keep that in mind. However, obviously, an out of range result can indicate a disorder. So it's very important to follow the doctor's advice and the network's advice and get any follow-up testing or evaluation done quickly so that those results could be either confirmed or ruled out.
Yeah, especially so sometimes some of the follow-up testing might include some genetic testing to look at the gene that's linked with a certain disorder. And that testing can take about a month to get those results back. So the sooner we can get started, the sooner we can, so it's a scary time for families to go through it. And then we're adding on another, oh, now we're going to take another 3 weeks to get these results. It's hard, right? So it's better to be safe than sorry, even if we say most of the time it's false positive. Mm-hmm. Hopefully it'll keep you a little calm. I know it's different when it's your baby and you're looking at them and you're scared, but it's good to get started on the testing right as soon as you can.
And yeah, you're right. I mean, it's 3 weeks could feel like 3 months, when you're waiting. So if they do need to be returned to have more testing done, where would they end up going? Is it to the pediatrician's office? Do they have to go to the hospital to get more blood drawn, or is there a specific lab to go to because they're babies?
There's a lot of labs in Connecticut that are options. Most families usually report having the best experience at Connecticut Children's in Hartford. They have a Quest lab on the second floor that anybody can go to. They work with babies on a daily basis. All of their phlebotomists are pediatric trained, and they have a full stock of pediatric supplies. There are other outpatient labs that we send babies to, many Quest labs, a lot of Yale draw stations, some other small hospital draw stations, and the results vary and patient experiences vary from one place to another. Some of these outpatient labs don't see newborns regularly, so they may not have staff that is as experienced in drawing blood on babies, or they may not have infant supplies readily available. However, if it is not convenient for your family to come to Hartford or to a Yale draw station, we have tried to work with Quest to identify some sites that have skilled pediatric phlebotomists. And we will reach out to the Quest managers and say, we have a baby in this area. Can you please help us find a good lab for them to go to? So I know that the lab situation for newborns in Connecticut is sometimes frustrating, but we're working really hard to try to make it a better experience for families.
Well, that's good. Yeah, because babies don't like that. And I just remember, the screaming and crying, oh gosh, that was terrible. But that's good to know. So that is really good to know.
I actually think it's harder on the parents than it is on the babies. So, because they're not going to remember it, or I think like Debbie said once, they don't have that anticipatory anxiety about a blood draw yet because they don't know what's coming. So and, you know, you just give them a bottle or a pacifier or breastfeed them right after, and, you know, they calm down pretty quickly. But yeah, it's harder on the moms and dads.
It really is. Oh my God. Yeah, it is.
Do you guys have any suggestions or tips on how to make the blood draw successful and run smoothly rather?
Ginger just had some great tips right there. If your baby uses a pacifier, bring a pacifier with you. If you're breastfeeding, you could put the baby to breast right after, or give the baby a bottle right after. Keeping the baby hydrated, starting the day before. If a well-hydrated baby is definitely going to bleed a little bit better than a dehydrated baby. And dehydration makes the veins harder to find. And I think that babies take a lot of their cues from you. So if you, as a parent, are very stressed and anxious about this blood draw, if you're frazzled going in, the baby's going to pick up on those cues. Whereas if you could maybe play some soothing music on the way to the hospital or to the blood draw station, if you could sing, give yourself plenty of time, relax and read a book while you're waiting at the office, the baby might pick up on those signals. And then during the blood draw, swaddle the baby if your baby enjoys being swaddled, and just let one arm out or one leg out, whatever is necessary. Keep the baby in a comfortable position. If the phlebotomist is okay, maybe you can even hold the baby or breastfeed the baby during the procedure. Or if you have to put the baby down on the table, you could still leave them swaddled as much as possible. And the blood tests many of the tests that we order take about 2 to 3 weeks to come back. So we will sometimes get phone calls from parents the next day or two saying, we had blood drawn, do we have the result yet? And I just want people to know that it can be a tough wait, but we do have to wait about 2 weeks for blood and sometimes up to 3 weeks for urine.
And speaking of urine, I mean, how do you even take that? I mean, like how, yeah, I mean, I didn't even know that. I thought it was all blood. So when I'm just curious.
Unfortunately do need urine for a lot of these tests. We have to compare the values in the blood to the values in the urine. So we need both, and we need them to be taken in around approximately the same time frame. So not only do we need a blood draw, but we ask for a urine sample to test as well. And this can be very challenging. The most common way of getting urine from a baby is to bag the baby. So it looks like a plastic baggie with a sticker around the edge that you stick on the baby, and they're supposed to pee in the bag, which you're then supposed to easily remove and dump in a cup and bring to the lab. But as you can imagine, there's a lot of mishaps along the way. So
I'm just going to state for the record, it's not that easy.
No,
One of my children had that, and it was definitely not that easy. But I can't imagine an easy way to do it. So that's got to be a difficult thing to get a urine sample from an infant.
We have a couple of suggestions. We're asking pediatricians' offices to help out with this. So if you're going in for a visit, ask the pediatrician or the nurse at the office to help you put the bag on the baby. And they usually have had some experience doing this and can get a pretty good seal. We also recommend putting some cotton balls or some gauze either in the bag or right around the bag, because most of these samples don't need to be sterile. They just need to be clean. So if you can even catch some of the urine on the gauze or the cotton ball, we can then squeeze it into the cup and get a little bit that way. We don't need a ton of urine. We don't need a full cup of it. Usually 5 milliliters is good for most of these tests. So it might be okay. I would then, from when the pediatrician or the nurse bags the baby, bring the baby right to the lab. So go from the office to the lab. You can take it off of there and put it right into the cup. And at the lab, they may be able to help you do that. Or if you're lucky, maybe the baby will even pee at the pediatrician's office and they can help you take it off there. If that's not possible, definitely ask for extra bags to go home with, because it might take you a couple of tries to get that sample. And after you're done and you have the urine sample, definitely use some barrier Desitin or Vaseline around the area, because it can sometimes become a little bit red or sensitive from the adhesive there. And once you have that urine sample, you want to bring it to the lab right away. You don't want to leave it in your fridge or on your counter for days.
And I will say that, you know, as much as people kind of get worried when they hear the term, like, oh, I have to go for a blood draw, but really when I talk to the families, they say the urine sample, getting the urine sample was harder. And now we kind of go like, it's liquid gold and it's gone. And yeah, so Debbie has a lot of NICU nursing experience. So she's like my go-to person to talk to families about what are some tips. I had one family say, we finally did it by putting him in the bathtub and held the bag over him while we dipped him in the water, because I guess he likes to go when he gets in the tub. But I mean, it's still a baby, but yeah.
There are some families, I think, especially families of boys, who say, you know, once they take the diaper off the boy, boys like to pee in the air. So they take the diaper off and then hold the bag over the boy. So he would pee in the bag, and it was like playing a game trying to collect.
Yeah. Now some of those families are like, now we can laugh about it, but at the time, yes, it's stressful and upsetting.
Oh, I'm sure. I can't imagine. Yeah. Having to do that. So now those results would go to like a Quest or to CCMC or.
Yes. So usually then you would have a sample cup, which you would label with your baby's name and date of birth and the date that the sample was collected. You would bring it right to either the Connecticut Children's Lab or the Quest Lab or whatever lab you had your blood drawn at, or the baby's blood drawn at, and drop it off there. They would ship it to be processed right away. And then we have dashboards where we monitor every baby who has labs pending and what date those labs should be due. So every day when I log in, I can see that this baby's labs should be due, and I can click in and see, are they ready yet? Are they here yet? And as soon as those labs result, we send them to the doctor and say, here's the case. This was the baby. These were the conditions that we were considering. This is how well he's doing. These are the lab results. What do you think? And then we'll make a determination. Either everything looks great and there's no further testing needed, it was a false positive and the newborn screening journey has ended, or we're concerned. We think the baby may have something going on. We may need to do genetic testing. You need to come in and meet with the specialist. We need to have some more conversations about this. So at that point, we'll reach out to the pediatrician, and then depending on the pediatrician's comfort level, or if we've had previous conversations or a relationship with the family, we might reach out to the family directly and say, this is where we stand. What questions do you have at this point? These are the next steps.
That's good. It sounds like it's, you know, it's all there, you know. I mean, it's a lot to take in, you know, especially like you said, for a parent to do, and it's a lot. But I mean, I think if everything just falls in the way it should, you know, it's a nice seamless process, you know, and having families be aware of what it really is and why we're doing it. And then getting the results, just that full circle is always nice, you know, because again, I mean, yeah, I guess it's still happening. I hope it's not happening now, but I know my kids are older than Joy's kids, and she was, you know, had the same results of not knowing, you know, so hopefully that is changing. And I know you guys are working hard to get that changed, and hopefully we can help with these, you know, videos and informational documents that we can share with families and so forth. So is there any other questions you think we didn't ask that you'd like to share with families? If there's any questions, you know, we can, do you mind if they contact you?
Absolutely, please feel free to reach out. I think we put our emails and contact information in the chat. Feel free to contact us with any questions you have.
Marty, are there any questions?
No questions right now. So I think we definitely covered everything.
Okay. And you shared their email addresses?
Yes, email and the website. So they can contact you directly for more information. I'll also put our contact email. So if anybody has questions for us, you can contact us directly as well.
Yeah. All right. So with that said, I mean, if you guys are good, I mean, like I said, I'd like to do something again, maybe in September, to hone in on something else, just to get, again, just to get the word out. We really want to make sure that families are aware of how important this is and why it's important. So hopefully, you know, we'll get together again in September to do another live with Debbie and Ginger.
Excellent. Thank you, Carmine.
Well, thank you so much. Don't leave, stay on. But thank you everybody for joining us. Again, if you have any questions, feel free to email us. The information is in the chat. Okay.